noches a todos. A nombre de la mesa directiva de Somera, les damos la bienvenida a esta, nuestra tercera sesión académica, que en esta ocasión vamos a tratar el tema de inmuno-radioterapia en cáncer de pulmón localmente avanzado, concretamente con el tema de aspectos prácticos de la radioterapia para el paciente con cáncer de pulmón de células no pequeñas, tratado con intento curativo. Esta sesión va a ser dictada por el doctor Moghanaki. Y bueno, quiero recordarles a todos que posterior a la presentación del doctor Moghanaki va a haber espacio de 15 minutos para preguntas y respuestas, por si gustan irlas formulando, y pueden enviarlas en cualquier momento para que al final de estas sean revisadas y contestadas por el doctor. Como introducción, podemos recordar que el poder hablar en este momento de un intento curativo, como vamos a escuchar en la charla del doctor Moghanaki, es gracias a los trabajos que se han hecho en las últimas décadas en el cáncer de pulmón, concretamente en las últimas fechas también lo que viene siendo la importancia de los trabajos del Grupo Pacific, nada menos el último del 2018 que todos ustedes conocen, que apareció en el New England, donde podemos ver que además de lo que ya se mencionaba en relación a la sobrevida libre de enfermedad, se pudo demostrar de una manera con un tratamiento seguro lo que viene siendo lo relacionado con sobrevida global. Algo que es fundamental destacar y que no debemos de olvidar es la importancia que tiene el efectuar en todo este tipo de pacientes que se sometan a este tipo de tratamientos, de protocolos, la importancia de efectuar una tomografía contrastada al final del tratamiento con la quimio-radioterapia. Sobre los pormenores de este tipo de manejo, el doctor nos va a ir ilustrando conforme vaya avanzando la presentación. Y bueno, en cuanto a la introducción del doctor Moghanaki, su currículum es muy amplio, son prácticamente 20 páginas, pero destacando, él es egresado de la Escuela de Medicina de Vanderbilt, efectuó la residencia en radiooncología en la Universidad de Pensilvania, también una subespecialidad en prototerapia en el Hospital General de Massachusetts. Actualmente es profesor de radiooncología en la Universidad de California en Los Ángeles, radiooncólogo del staff del VA Greater de Los Ángeles Healthcare System, y es miembro fundador del Grupo de Trabajo de Radioterapia Paliativa de la Administración Nacional de Salud de los Veteranos, entre otros múltiples cargos. Es chair, además, en diversos comités de grupos de trabajo también, moderador en diferentes conferencias, revisor para Astro en diferentes grupos. Por supuesto, tiene publicaciones en diversas revistas como Practical Radiation Oncology, American Journal of Clinical Oncology, JAMA, etc. Diversas publicaciones, más de 43 en revistas internacionales, por supuesto también capítulos de libros de texto, y últimamente sus publicaciones están más enfocadas en lo que viene siendo SBRT, concretamente en pulmón. Sin más preámbulo, entonces cedo la palabra al doctor Moghanaki. Muchas gracias por aceptar la invitación y les recuerdo estar enviando por favor sus preguntas. Muchas gracias y adelante.
Thank you for that introduction. It is a pleasure to be here. Some of you may have heard me speak last year at the Society annual meeting, and it's nice to be presenting to a group of radiation oncologists. So let me share my slides. So my only potential conflict of interest, I was not paid to give this talk tonight. However, I did join a steering committee with AstraZeneca last year during the pandemic by Zoom. I want to go over 5 general topics in radiation oncology. I was asked to speak about technique and selection and strategies to minimize potential harms of treatment, since we know radiation can be very effective. I will focus on early stage and then discuss some recent problems with SBRT for ultracentral tumors. We'll talk about locally advanced and adjuvant immunotherapy with durvalumab. And also what has become, I think, the most exciting area in radiation oncology, using radiation in people with stage 4 lung cancer. So my talk today will just focus on lung cancer radiation therapy. So for early stage lung cancer, I will start with a case a patient who has no symptoms, and so they would only get a scan for other reasons. Maybe they have a lung screening scan, or maybe they had a CAT scan for some other reason. Maybe a chest x-ray found a nodule before some sort of operation, such as for a kidney stone or something unrelated to cancer. We like to compare our scan to previous scans to make sure it's growing before we do any biopsies or anything. We like to get PET scans to look for nodal disease anywhere else. And in a patient like this who has no prior cancers, we're trying to figure out, do we think this is lung cancer or something else? What do we do? Our evaluation best practice is to get a PET scan, and we always biopsy whenever it is safe. We don't like to treat without tissue. We like to measure the cardiac and pulmonary function, mostly to see if surgery is an option or not. We then like to evaluate the hilum and mediastinum with bronchoscopy or mediastinoscopy. The research has shown really no measurable difference between these two techniques. Many surgeons do both. Sometimes the surgeons stop doing this and they only have the respiratory physician using bronchoscopy to sample the lymph nodes. And the best way to provide care for lung cancer patients is with a team, especially now that we have to think about chemotherapy and immunotherapy in addition to all of these staging studies. So we often need to have pulmonary and radiology and surgery involved to make the decisions. I have actually trained in general surgery 1 year before radiation oncology, and I have forever believed that a radiation oncologist cannot determine whether or not a patient is operable. Only a surgeon can do that. Once we decide a patient has early stage 1 lung cancer, the details of treatment planning are important. When it comes to simulation, there are lots of equipment that you may consider buying, but nothing is more important than the patient comfort, because we want to make sure the patient doesn't move. We, of course, want the arms up so that we have maximum options for bringing in the beam from the front, back, or side. Many people are now using arc-based therapy, so we don't want to go through the arms if we can avoid it. And whenever possible, I strongly encourage a 4D CT scan. I know that many clinics do not have this. I would encourage you to keep asking your administrator at the hospital to purchase the software. Most CT scanners can do 4D CT acquisition, and all medical physicists can learn how to do this. It gives you the best picture and video of the tumor so you don't miss the target. Here is an example of a 4D CT from the university where it was first developed in the mid-1990s, Virginia Commonwealth University. As we can see, once you can visualize the tumor, you know which direction it's moving in and get better at contouring to not miss. So the complete movement of the tumor through the breathing cycle, we call it the IGTV. And when you know the IGTV, your treatment plan will not miss the tumor no matter where the patient is in the breathing cycle. Of course, this is an image that you get before the treatment, and you will get a cone beam CT hopefully on your machine at the time of treatment. And you hope that when the beam is on, the tumor stays within this area. The good news is most of the time it does, because we found that the outcomes with SBRT for stage 1 lung cancer seems to be the same no matter where it's being treated, what machine is being used. So this technique of using an IGTV seems to be reproducible in many countries around the world. When we evaluate a 4D CT, it is important to have a basic understanding. If you don't, please take the time to learn. Free breathing CT, you will see a smearing of the tumor, and it may be hard to define where it is. The MIP, the maximum intensity projection, will give you a best guess scenario of all the places the tumor is during the breathing cycle. It is the easy way to do the contouring, but you still want to go through every phase of the breathing cycle. In certain softwares for the treatment planning system, you can actually click the play button and watch it move to make sure it never moves outside of your IGTV contour. Here, the red line is the IGTV. The orange line is your PTV margin, because you know at the time of the treatment delivery, there may be some assumptions that are wrong, and it's better to have a little bit of extra margin to be safe. So we know that tumors move, and this can apply to locally advanced disease as well. And we have two options. Let the patient breathe and include all of the motion in the IGTV. The second option, and it requires the patient to have better lung function, is to try to reduce the motion. You can try to compress the belt. You can buy a $20,000 piece of equipment to try to squeeze the abdomen so that there's more rib breathing. You have to squeeze quite a bit for the diaphragm to stop being the dominant form of breathing. And the good news is you can buy actually a very inexpensive weightlifter's belt and put that on, and sometimes that at least can get you some compression, if not enough. I visited many radiation oncology centers, and many of them don't do any compression at all. Another way to reduce motion is to use gating, where you only treat the tumor when it comes back into the beam. So you don't treat it when it goes out of the IGTV, or you treat it when it comes back into it. This requires some more advanced technology, and the team needs to understand how to use it. There has to be some assumptions, but it is very accurate when you use it. It is best when you use fiducial markers, so you can take x-rays like some of the CyberKnife machines or the TrueBeam that uses triggered imaging. So as your machine is treating, you can take x-rays and make sure that the tumor during the open gate time, the tumor is in the right location. Beacons have been used, such as Calypso. However, they're not widely available to my knowledge. Now, when it comes to designing the PTV, once you have an IGTV, most people will use a 5mm isotropic expansion around this. This seems to be generally well accepted by most key leaders in the world. We have to be careful about the structures. However, we don't want to make the dosimetrists upset at us, and we have to pick only some that we call critical, and the others we will call non-critical, because we can't always meet every constraint. But there are 4 important critical structures that we should never overdose. Of course, the spinal cord. Be careful of the brachial plexus for tumors up in the apex. The esophagus, we have seen many reports of esophageal perforation with high SBRT doses, and the proximal bronchial tree, which I'll talk about in the next section. When designing the radiation treatment plan, we like to make the dose as high as possible on the inside. The hotspot can be 125, 140, 160%. It is okay. Big doses of radiation cause late effects. We like late effects inside the cancer. And in fact, the optimizer likes it when you allow high doses to go on the inside. It then doesn't have to work so hard to flatten the dose profile, because that pushes intermediate dose outside of the tumor. So allow it to get hot, but keep the hot inside the tumor and away from any critical structures. Of course, the dose drop-off should be compact. You want all the high dose to be only within a couple millimeters of the tumor. And when reviewing the dose volume histogram, please also review the isodose lines. It is important to look at all the places where the tumor is going. My preference is to use the dose color wash. That way I can start from 0 and go up to 20 gray, 40 gray, 50 gray, and see the shape of the radiation to make sure we don't have streaks of intermediate dose in different directions. It's very important to look at it in all 3 planes. Now, I want to give one warning about SBRT planning. If you can see the tumor, if there is unaccounted movement in the lateral or medial or anterior posterior direction, you have plenty of extra incidental dose. But superior and inferior, the dose fall off is very, very sharp. So, and we know that breathing uncertainty, that's where it's going to possibly go outside of your dose, either above or below. Be very careful when contouring the top of the IGTV and the bottom of the IGTV. And if you do not trust your image, if your quality is poor, you might want to add a few more millimeters of PTV above and below. Some people use 8 millimeters above and below just to be safe. Of course, that comes with a little bit more toxicity, so you have to weigh the risks and benefits. Assessing the quality of your technology, good idea to talk with your physicist to decide whether you need that extra 3 millimeters or not. When reviewing the plan, we like to look at the high dose area, make sure it's as tight as possible. 18 gray times 3 is a lot. You don't want 18 gray times 3 going to normal lung tissue. You should also look at the 50%. This is now 9 gray times 3. This is still a very high dose, and it should be as compact as possible. And lots of clinical trial protocols provide tables for how much of a volume it should be. We normally look at the 50% volume and compare it to the PTV volume and do a ratio depending on the size of the PTV. If you're not familiar with this, please ask someone who knows where these tables are. They are being sent by email all around the world, and we're all using basically the same one, originally developed by Timmerman and his colleagues. Some more pearls to remember. I do not really use PET-CT for fusion unless maybe there's some atelectasis. Stage 1 lung cancer is best seen on a good quality CT scan. You can use 3D planning. You don't have to use IMRT. You can use step and shoot, but if you use step and shoot, you should have at least 10 fields. You want to, just like a gamma knife, you want to spread out the dose as much as possible to minimize the area where the high dose is. You can use something called a conformal arc. It's an arc, but it's 3D planning. There's no modulation. So it's simple to QA. There is no matrix phantom checking required. But if you want to modulate the beam, such as with VMAT or step and shoot, you do have to do a quality check for QA, and that will add 1 extra day before the patient can start. I often use IMRT. I allow the dose to go very high. It allows the treatment planner to try different angles and different modulations. And only sometimes does the conformal arc work. It has to be in the right location for it to be okay without modulation. There's many prescriptions to consider, all the way from 4 gray per fraction, which I don't really think is an SBRT. This is more hypofractionation. The BED is lower, to the 7 gray times 10, which is the MD Anderson preferred technique, all the way up to 3 fractions. And you may have heard of the 1 fraction regimen. There's only a few institutions that have reported their results with the 1 fraction. The toxicity rate is only 1% for grade 3. It's a good option. Sometimes the patient will be tired the next day from such a big dose, but if your target is small, right now there's 2 randomized trials that show no difference between this fractionation and other standard fractionations such as 12 gray times 4. So it is a reasonable standard of care that was used a lot in the pandemic. I use it a lot in my older patients or other patients who have difficulty traveling for their care. For tumors that are central in more high-risk area, we never use 1 fraction or 3 fractions. We think about these other gentler. They're still high doses. 12 gray times 4 is still a lot, and you can still run into trouble, but we'll talk about that in the next section. After SBRT, I always tell my patients that we will be monitoring your scars from the SBRT. Here is a patient of mine. I treated him with 18 gray times 3. At 6 months, I get my regular scan. There looks like to be a little scarring here. And then next scan, I don't know what this is. Is it scar? I don't think it's cancer. Cancer doesn't grow this way. I didn't wait 6 more months. I waited only 3 months. I got another scan, and it looks like the scar just collapsed on itself. Now it's only 15 months. You don't know what it is. The right thing to do, if you are concerned, next step is get a PET scan. If the PET scan is hot, you still don't assume it's cancer because scars can have PET activity. You then should get a biopsy before you do any sort of additional treatment, such as maybe surgery, maybe another SBRT, or maybe systemic therapy. And if you want to do additional SBRT, it really should be in a very safe place, far away from big blood vessels and far away from the central mediastinal structures. Now, there's a very interesting paper that's now 4 years old that was published with 88 patients who had no relapse. And you can see here what happens to people who don't have cancer relapse. So here's a planning CT. It got smaller and smaller, and everyone was excited. And then at 9 months, it's starting to get bigger. Is it scar or is it cancer? The next couple of years, you can see this thing seems to be retracting from the chest wall and maybe is smaller and then gets bigger again. This is concerning. People will start getting PET scans and biopsies, and you could consider maybe that is a harm because the patient doesn't have cancer. And maybe if they had surgery, you wouldn't have to deal with this. Later on, it gets maybe bigger, maybe smaller, maybe bigger again. 3 years must be relapse. Well, they didn't do anything to this patient. You can see it just got smaller and smaller. So be aware of this. Teach your radiologists. Many of them don't know this, and try to reduce the number of PET scans and biopsies in patients. Just be patient, know the data. SBRT has 95 to 98% tumor control rates, very, very high, and it's easy to be worried about your patient. There are different tools to try to predict when it's a scar versus radiation, a scar from radiation or cancer, and those tools are not very good. So you have to use the best judgment you've got, maybe pray to God, and God can tell you if it's tumor or scar. Now, if you end up with a relapse after SBRT, the good news is in selected patients, you can have good outcomes with surgery for salvage. This is a report from MD Anderson, and they pooled 4 institutions' data, 37 patients, half of them were men, and the median time from SBRT to failure was 16 months. All of these patients had pathologically proven relapse. The SBRT was given most of the time for lung cancer, but sometimes it was given for oligometastatic disease. The surgery most of the time required an open thoracotomy, 92% of the time. The adhesions were found 50% of the time, where the surgery was a bit more complicated. Most of the cases required a lobectomy, but some could be resected with sublobar, such as wedge or segment resection. They were able to get 100% negative margins, and the good news, something to teach our surgeons, is that the SBRT related mortality was 0%. There was one patient who died postoperatively out of the 37, but it was not related to the SBRT. I believe they had a cardiac complication from anesthesia and lung surgery. Here are the outcomes. So green is the oligometastatic patient. There are 26 that had lung relapse, and at time of surgery, their second chance for cure is still here. Something to know and discuss with patients when they worry about, if I get SBRT, can I still get surgery? Now, this issue of ultracentral lung tumors, I thought was important because there are now 3 publications this year that showed high risk complications after SBRT. I want you to look at these 8 SBRT cases and try to tell me which one of these patients did okay and which one of them died from a fatal complication. I have bad news to share. They all died from fatal hemoptysis. The study was published in JTO earlier this year. It was the Hylas trial, phase 2. They started with the assumption that 7.5 gray times 8 fractions was safe. So the study was designed to measure the local control rate to make sure the control rate was good enough. Unfortunately, it probably should have been a phase 1 trial to measure the toxicity for assuming it was safe. Here are two more cases. Look at how large the field was. These are stage 1 cases. The PTV is large, and the patient on the left died of a fatal pneumonitis. Too much moderate dose I see here is going into the right upper lobe. And on the right here, the trachea, the tracheoesophageal fistula occurred as a result of this large field. So this is a problem. If you go back in time, the word ultracentral was originally written about in this paper from Stanford. I am unaware of any other papers before, maybe there is, but this is the only one this is the first one I know. And at that institution, they used CyberKnife, they used Trilogy, they used TrueBeam STX. And of course, you know, Stanford is where they were doing the 25 grade times 1 for pancreas cancer and had severe complications. But they did not have severe complications for these small targets using these different techniques. CyberKnife, as we know, is non-coplanar. I'm not sure if the Trilogy or TrueBeam STX use non-coplanar or not, but you can get much more conformal with non-coplanar. And if you have a small target without a lot of PTV expansion, maybe it's safe. In their experience, between 1 to 2 years of follow-up with 7 patients, they had 0 fatal toxicities. In fact, they had 0 grade 2 toxicities. They divided the risk zones into trachea, primary bronchi, and then the branches and generations, and each of these generations is seen to be okay. The next big paper on ultracentral came from Memorial Sloan Kettering. Unfortunately, they had an 11% death rate. And the paper that they published in JAMA Oncology suggested that it was because of the anti-VEGF drugs that they were on. So maybe this affected the vasculature, and so the SBRT doses were too high. Maybe they should have lowered the SBRT doses, but look here. Hypofractionation, 4 grade times 15, was still not safe in these patients. They even had a patient who had no VEGF inhibitor, and like the HILAS trial had the 7.5 times 8. Below here are more SBRT-like doses, and they divided into likely treatment-related complication, death, or possibly treatment-related. And I think that this right column is interesting, is that these severe complications happen very early. So we should be aware of it if it's happening. And it's interesting, in the patients who did not have the VEGF inhibitor, the fatality rate was still 5%, but you could turn this around and say, hey, 95% did okay. They didn't die from the SBRT to the ultracentral lesion. So this should also be discussed. We can't just get scared and say, I'm sorry, there's nothing I can do for you. You can still do it, 95% chance without VEGF that you'll be okay, but you should be honest with the patient and the family. We might have a severe complication. Here is the other graph from this paper showing that for ultracentral tumors, no angiogenesis inhibitor, not so bad. With angiogenesis inhibitor, close to 50%. I want to emphasize the importance of getting contrast if you decide to use SBRT or any hyperfractionation for ultracentral tumors. Here is the mediastinal window. Here's the lung window. These two scans are without contrast. If I was contouring this, I'm not sure what I would contour. Just use some contrast. You can reduce your volume by half by not contouring a major pulmonary vein, as is highlighted here by the contrast. So for central tumors, I will use IV contrast. For peripheral tumors, I don't use IV contrast. When it comes to treatment planning, a lot of people still use this from 0813, and this is taken from the protocol. You know that if you have an ultracentral tumor, the GTV is going to touch the organ at risk. The PTV, you should not shave the PTV. Let it go into the organ at risk, but don't let the high dose go to the organ at risk. Keep the high dose away, and in fact, keep it far, far away, because sometimes while the beam is treating, the organ at risk might move in and out of the hot spot during the treatment. In the HILAS trial, they allowed up to 150% hot spot, and maybe while the patient was breathing, the bronchus went in and out of the 150 hot spot. We don't know because we don't have real-time images during the beam delivery. It's important to know that 0813 also was not completely safe. They also had a 5% ultracentral fatal toxicity rate. So it's kind of a concerning area to treat in. So I want to be sure everyone is aware of this. So again, don't make it too hot for this one. For this one, you might want to lower the hotspot to 110%, maybe 115, but not more than that. Now, what is the central zone? We used to define it around just the bronchus. So the definition of central used to be just the proximal airway. However, the IISLC helped us realize we should really consider the heart, these major vessels, and the brachial plexus, because the tumor who's over here could be close to a coronary artery that could be injured by SBRT. A tumor over here could lead to high doses to the brachial plexus. So we like to think about all of these areas when defining central. I want to just introduce this concept of MRI guided radiation therapy. I talked to the company ViewRay. I think they don't have any machines in Mexico at this point. I didn't ask about Latin America. But what's amazing about MRI guided, in some tumors, you cannot always see the stage ones, but in some of them, you can actually see the tumor while the beam is on, so you can watch it and be sure that it doesn't go outside of the PTV. This is the first time ever, I believe, that we're able to see the tumor while the beam is on. And here's a video that I asked the company to send to me that shows that you can see here. And when we talk about ultracentral, the esophagus or other structures, this will make sure that we don't accidentally treat the wrong area. And we know that patients move, and it's really interesting to have the MRI on the whole time to see where the tumor is going in case it moves differently on any given day. I now want to move on to locally advanced lung cancer. So obviously when a patient shows up with a workup, we have to get a PET scan to see all the areas. Here you have a supraclavicular node. We should always get an MRI. These patients have a high risk of brain metastasis. This is before we do any treatment at all. We know that the options often can be chemo followed by surgery, with or without radiation. And a patient with a supraclav node probably will not go this option. Preoperative chemoradiation followed by surgery is very toxic and not used very often. What has now become the standard of care is concurrent chemoradiation followed by 1 year of durvalumab. Now, if the patient is sick with poor performance status, probably the better idea is just use sequential chemotherapy and radiation like the Dillman trial showed. This is better than just radiation alone. And of course, if you just have to use radiation alone, well, the patient probably is not going to do very good. Back to the issue of simulation, very similar to early stage. 4D CT whenever possible so we can reduce the volume of radiation. The volumes are already very big. We know that durvalumab may cause pneumonitis. We know radiation may cause pneumonitis, so we have to be even more careful. So always get a 4D CT so you don't have to guess how much PTV expansion to put. Always get IV contrast for the hilar area, like I showed. The PET CT fusions can be helpful, but be aware of misregistration. Use a lot of fields. Do not use 4 fields. Use 6, 8, 10. Reduce the area of high dose. It is high doses that causes toxicity, not the low doses. I don't really care about the V5. I care about the V50, the V40. These are very high doses. When it comes to planning, IMRT sometimes actually can be simpler than multi-field 3D planning. Talk to your dosimetrist, they will tell you. When it comes to defining the GTV, we're only targeting what we can see. Very few of us treat elective nodes anymore. We use the CT, the PET, and the EBUS findings. So if they tell us some lymph node stations are positive, we'll target that. Obviously, we do the IGTV. We use the CTV to expand microscopic disease. Now, the normal is to expand the primary tumor 5 to 8 millimeters. Many of us use less. I will sometimes only use 3 millimeters or maybe 5 millimeters, especially if they're also going to get durvalumab. And but the lymph nodes, you might want to expand a little bit, but not more than 3 millimeters. And then with PTV minus CTV, you come up with some sort of expansion of up to 1 centimeter. depending on what your therapist and what your film checks show you. If your team is very good, maybe 3 millimeters, probably not. 5 to 7 is what most people use. And if you do not trust the therapist, you don't trust the imaging, you should probably add 1 centimeter to be safe. How much dose? Most people are stopped at 60 gray. These data are reliable. This was a randomized trial. More was not better. More was worse. Maybe in some situations you can give more, but please be careful. And communicate your image guidance radiation therapy techniques clearly to the therapist. How do you want them to set up every day? Do you want MV, KV, cone beam CT, or combination? How often do you want it? Daily, weekly, or other? In my institution, we write this in the prescription so they know. What structure do you want to align to? The carina, the ribs, or the tumor? If you don't say, they have to guess. And then think about the expansion. This will help you decide how to set it up every day. Now, what is this whole business about immunotherapy? Well, just a very simple lesson about PD-1 and PD-L1. Checkpoint inhibitors. T cells get confused when they're surrounded by PD-1. They don't know where to go. If you give them a PD-1 inhibitor, and here are the 3 that are approved by the FDA, they turn on and they can go after the cancers. These are PD-1 inhibitors. PD-L1 is actually what is activated around the cancer cells. And it turns out that while you're giving treatment, such as chemotherapy and radiation, they start growing this resistance, this PD-L1, to hide from the immune system. This is why right now there is a Pacific trial that actually is adding durvalumab during the chemoradiation to get these cells before they develop this resistance. But nonetheless, afterwards, if you give them the PD-L1 inhibitor, and there's 3, but only one of them has been shown to help in this situation, the cancer cells will lose the PD-L1 protection and now be susceptible to your immune system, your T cells. So the Pacific trial, here are some of the details. The patients were all stage 3, unresectable, and the PD-L1 status actually didn't matter. They enrolled all patients. After 6 weeks of chemoradiation, they confirmed no progression and no toxicity. You don't want to take a sick person and give them durvalumab. And that no progression was what was discussed earlier. Make sure you get a CT scan scheduled so that they get it within a month. I'd like to send the patient back to the medical oncologist, finish the radiation, nice and healthy with the CAT scan. Here you go. Good luck for 1 year of durvalumab. These are the results that were in the Pacific trial. Half were stable, half had a partial response, and 2 actually had a complete response with the chemorads. Not very good, but it shows that sometimes it's enough. The randomization of this trial was 2 to 1. 2 got durva, 1 got placebo. And what's amazing is with 12 months of treatment, it was double blinded. The patients who were randomized to placebo came and sat in a chair and got placebo. And here is the first publication in 2017, progression-free survival benefit, very big difference, but we have to believe this works only when the overall survival is different. The next year in New England Journal, we saw the overall survival benefit. So the last slide, this is 14 months of follow-up. Now we have 25 months of follow-up, and the 2-year overall survival benefit was 10%. The median survival, 28 months versus not reached. Here is the 24-month survival difference, 55 to 66. Now there's actually been an updated publication last year with a median follow-up of 33 months, and the curves are still diverging. The 3-year overall survival benefit now is 14%. We just haven't seen anything like this for a long time. And look at the median survival. Still, the durvalumab, the median survival has not been reached. So it's over 50%. Here it is, 57%. This gives us a lot of hope when we talk to our patients before they begin treatment. What about side effects? Immunotherapy is new, it's gonna be scary. Well, it turns out that you can have some more severe side effects, but even with the chemorads with placebo, you still had 23%, but it's real, it can happen, but you saw the overall survival curve. So it's worth it as long as the patient you think doesn't have any contraindications. Fatal events due to side effects was actually less with the durvalumab. So it looks like we're not the severe adverse events isn't leading to durvalumab more deaths in that arm. And the most frequent reason for discontinuation was pneumonitis. Like I said earlier, durvalumab causes pneumonitis, radiation causes pneumonitis. We don't think there's a synergy between the two. We think they just add to each other. Now, again, treatment planning, sometimes these cancers are very large. Here's someone with 3B disease. You do your best to keep your doses, meet your dose constraints. And sometimes in a patient like this, look how big the fields are. You might not want to add 8 millimeters of expansion to the CTV. Here's a patient you might want to go smaller. So if they survive their lung cancer, they can actually breathe. It's been a great journey since the 1990s, where we just started with radiation alone. Then we added chemotherapy before radiation. Then we added chemoradiation. This is the best treatment. And with Pacific, here we are. We've made progress every decade, and it's been fantastic to be a lung cancer radiation oncologist. The last part of my talk is about the future, or maybe the present for some. We have this concept of oligometastatic disease, and there's 3 different types. The oligopersistent, which means you keep giving systemic therapy, but there's a few tumors that persist. Oligoprogression is you keep giving systemic therapy and a few of them start to grow. Oligorecurrence means maybe you got rid of everything on the scan and then a few returned. We're not clear in which patient the radiation would work better in, and it's being studied in all 3 of these groups. And why would you treat oligometastatic disease? So here is a paper by David Palma's group that shows here you have your M1 and M2 metastasis from the primary tumor. M1 goes to liver, M2 goes to the bone, and you leave it there. And then from the bone, it goes to the, from the liver, it then goes back to the lung. And then from the bone, it goes to the brain. So what if you treated the liver and the bone? Maybe you could prevent it from going back to the lung and the liver. So this is the concept now that's now been studied to say maybe we should be getting rid of the resistance tumors sooner rather than waiting for it to spread more. So there are 2 phase 2 randomized trials. The first one was closed early because the effect size was so big. And this other one had a lot of patients, only 18 lung cancer patients, but also the effect size was very impressive. In the oligometastatic trial, 50 patients, you can see the progression-free survival very significant, and here the overall survival from 17 up to 41 months, more than double of survival by consolidating those oligopersistent cancers after systemic therapy. The Saber-Comet trial, which had a bunch of different cancer stage 4, also once again showed a survival benefit and justifying the importance of delivering this treatment. Now, these aren't phase 3 data. You need to wait for more. But if you don't have a phase 3 study in your clinic, I think it is appropriate to treat these cancers before they spread to more spots. My take-home messages are as follows. Clear communication about what you're planning to do and how you want to set up your patients improves the treatment planning and the delivery. Otherwise, people in the department have to guess what it is that you want. SBRT is safe with grade 3 toxicity rates around 1%, but it is not always safe with ultracentral tumors. Adjuvant immunotherapy with durvalumab helps people with stage 3 lung cancer live longer. And interestingly now, radiation therapy helps people with stage 1, 2, 3, and 4 lung cancer live longer. And that concludes my presentation. Happy to answer any questions.
Gracias por la presentación, doctor Moghanaki, excelente, especialmente en la parte de SBRT, que es un tema en boga. Para esto, nuevamente felicidades por la presentación. Hay algunas preguntas, algunas de ellas se tocaron lo del tema en la presentación, pero me voy a permitir de cualquier forma hacerlas para que quede más claro la misma. El doctor Efraín Martínez pregunta, ¿qué porcentaje de dosis por arriba de la dosis prescrita permite como máximo dentro del PTB?
We use principles similar to Gamma Knife, and if you're far away from a sensitive critical structure, 167% should be okay.
Gracias. El doctor José Manuel García Ramírez, ¿cuál es la definición que utiliza para tumores ultracentral? Creo que se vio, pero si pudiera, por favor, reforzarlo.
Sure, that is when the tumor is touching one of the central mediastinal structures. Usually, we only worry about the proximal bronchial tree, but I would consider a tumor touching the heart or the esophagus to also be ultracentral.
Excelente, gracias. ¿Es válido, de parte del doctor David Adame Barajas, es válido la técnica de 2D, aumentando el volumen a todo el lóbulo? ¿Qué es lo que estiparía el cirujano? Es textual la pregunta en español. No me queda muy clara la pregunta como tal.
Si puede, try again to...
Perdón.
Yeah, I don't understand the question.
No, si pudiera, doctora, dame volver a formularla, con mucho gusto se la pasamos al doctor. Otra pregunta. En tumores ultracentrales, ¿qué tipo de SBRT utiliza más frecuentemente?
I was worried you would ask that question. I like to use the 10 gray times 5. I also like to use our MRI machine. I also like to use lots of beams. And I also like to reduce the medial margin by up to 3 millimeters only for PTV. And I sometimes will ask my medical oncologist, will you give chemotherapy for 6 weeks of 2 gray per fraction? They almost always say no, because there is no indication for chemotherapy for stage 1 lung cancer. So I go with the 10 gray times 5. Sometimes if the tumor is larger, I will use the 4 gray times 15 fractions, but I will always tell my patient there's a chance you may develop a severe complication from this. And it's very similar to conversations when surgeons say you may have a severe complication from surgery. But I always treat it.
Okay. Nada más recordarles que las preguntas pueden hacerlas en español, porque de cualquier forma, como se tiene la traducción simultánea, tengo que leerlas en español para que posteriormente se haga la traducción en inglés. El doctor Armando Félix pregunta que en el caso de tratar de forma bilateral, metástasis de forma bilateral, ¿cuál es el número máximo de lesiones que trataría? Y en el escenario de que existan lesiones bilaterales, si trata las lesiones centrales junto con las lesiones periféricas. Y finalmente, ¿cuál es el número máximo de dosis que recomendaría y los constraints?
So there's 2 parts to the answer. One is whether we should give any radiation at all. So the clinical scenario needs to be very good. It would be I would only do it in a patient who had stable disease for a while. And I think we're talking about maybe 3 to 4 lesions all in the lung. In that situation, there are some papers you can look up which talks about composite dose to the lung, but it's not just the lung. I mean, pneumonitis can be a problem, but you also have to think about each critical structure by itself. I would do a composite plan of all of the beams. I would try to use non-coplanar beams whenever possible. And again, I would seriously consider whether it makes sense or not to treat that many targets in the chest. When we treat 4 lesions, we're usually not treating all of them in the lungs, maybe 2 in the lung, and then an adrenal, and then a bone. But in my experience, I've never treated more than 3 in the lung.
Gracias. El doctor José Manuel García, en pacientes con recurrencia después de quimioterapia y radioterapia y que hayan sido además tratados con durvalumab, ¿es posible de efectuar un tratamiento de CBRT de rescate?
Again, two parts to my answer. The first one is whether if it was actual progression of previous disease or if a new lung cancer developed, which sometimes, I have a patient right now, I treated his large 3A disease and he has a new lung nodule on the other side. I don't know if that's a new stage 1 lung cancer or if it's a stage 4 metastases. So that's the first step to figure out. Once it's decided, then again, you determine whether it makes sense to go ahead and give more radiation. I think in a patient who has progressed, you have a radiosensitive problem. I'm going to assume in this patient you did a PET scan and there is no other cancer. So now the question is, do you treat now or do you switch to another drug therapy such as carboplatin with pemetrexed and pembrolizumab? Carbo-pem-pem is a good next line. Maybe you want to give that and wait, and 6 months later, if there's no metastasis, come back and treat. The reason I like that option is because maybe your target will get smaller. If you have a good response to a different checkpoint inhibitor with chemotherapy, maybe you end up in a better place. But the reason I also don't like that answer is the data shows that the earlier you treat, the better, before that resistance progression grows and now becomes out of control. It's a very tough choice, but I just put these two options for you to consider if you have this situation.
Gracias. Igualmente el doctor José Manuel García pregunta su opinión sobre el tratamiento de cráneo total como profilaxis.
Cranial treatment?
Yeah, whole brain radiotherapy.
Yeah, whole brain. So we don't do it for non-small cell, but for small cell, both limited stage or extensive stage with a negative MRI, 24 gray is where I stop. If I'm in a clinic with good physicists and dosimetrists, I will do hippocampal sparing. I will also give the patients the memantine drug, especially the limited stage patients who has a good response, because they might be the ones who will live 5 years or longer. And I would like to do everything to minimize memory loss.
De acuerdo. El doctor Enrique Gutiérrez Valencia, que se encuentra actualmente en Canadá, él es egresado de aquí del Centro Médico Nacional de Occidente, lo felicita por su excelente presentación. Nuevamente pregunta en el escenario de oligometástasis, es una pregunta similar, ¿cuál es el número máximo de lesiones que trataría?
Yeah, again, I look at where it is, and there is a paper by Ritter, R-I-T-T-E-R, et al. And Ritter, his first name is Timothy. And he wrote a paper about this with the Energy RTOG group to figure out how do you add up all of the doses. But, you know, whole body dose is one thing. It really, again, comes down to structure by structure. I like to put myself in this mind of a surgeon. What would a surgeon do who has to cut 3 or 4 different times? Well, every surgery, the complication will depend on where they are operating. Obviously, the overall surgery and the anesthesia to cut 4 different areas has an impact, but also what you remove from which part of the body. I would consider all of these things together when talking with the patient to decide whether we should do it or not. Because in these patients, we're not going to cure them. The goal is to get more mileage so they will live longer. The goal in my hypothesis is that the reason radiation to these smaller lesions helps people live longer is because they may have only 3 drug options. And if they're on drug number 1 and they have progression, the best chance for them to live longer is to stay on drug number 1. Because once they go to drug number 2, the effect, the benefit goes down and they're on drug number 3, drug number 4, and then they're sick in the hospital. So I use radiation to keep them on drug number 1. And sometimes 5 gray times 5 might be enough. Anything to make the medical oncologist comfortable, to stay on drug number one, get more mileage out of drug number one, and don't switch too early.
Gracias. Si pudiera, en este caso, bueno, la nueva pregunta del doctor Enrique Gutiérrez, si recomienda la interrupción de la inmunoterapia antes de un tratamiento de SBRT en pulmón, y de ser así, ¿cuántos días recomienda interrumpir la inmunoterapia previo, cuántos días antes interrumpir la inmunoterapia previo al tratamiento con SBRT?
I talk with my medical oncologist about this, and I open papers to read about it. And it's interesting that there are papers written about this, but they are all opinion papers. There's not enough data to know for sure. But generally speaking, if the medical oncologist said, I want to keep them on the immunotherapy, I am okay delivering the SBRT with immunotherapy on. I don't feel there's a need to stop it.
El doctor Luis Manuel Colín, si puede recomendar alguna bibliografía, la que considere más útil, para donde se puedan encontrar las dosis y protocolos existentes para SBRT de pulmón.
So there are the most contemporary clinical trial. There's 3 lung SBRT trials for inoperable patients. The first one is the Pacific 4 trial. So if you can get a copy from someone, that would be good. The second one is Keynote 867. That is a Pembro trial. And the other stage 1 lung cancer is SWOG 1914. So these have the most up-to-date protocols for dose constraints and coverage. Our VA phase 3 Valor study, I am just right now writing the protocol for the first time to put these dose constraints in the literature. All of these are generally coming from the same place, which is Bob Timmerman's brain. And we are all following whatever Bob Timmerman recommends, making maybe some small modifications. Some of it comes from TG101. Most of it comes from, additional information that we've learned. But those are the 3 most contemporary protocols that I would refer to.
Gracias. El doctor Moyao pregunta si puede omitirse el diagnóstico histopatológico en algunos casos y cuáles serían.
I always ask for biopsy. I always ask the patient, the radiologist, the surgeon for biopsy. I only treat when they all say no. If nobody will biopsy, what are you going to do? Then you have to decide whether this is cancer or not. And the best way to do that is find the smartest radiologists that you know. There is a difference in radiologists. Some of them don't really understand chest radiology. Others are brilliant. They understand the ground glass, the subsolid. They can identify benign things like hamartoma, atresia, granuloma. And I work with them. If no one's going to biopsy, I work with the radiologist. I have a patient right now, same thing, ground glass with a little solid part. 4 years it's been stable, but she's going crazy. She should treat me, please. I want to take care of this. And I don't know. They did a biopsy actually, and they didn't get confirmation. And sometimes you actually do the biopsy and you still don't get confirmation. So in that situation, I will, if this person, my patient is young, I don't want her in 2 to 3 years to have node positive stage 3 disease. So we're going to go ahead and treat that. And we do this a lot. Now that is only, I think it's a 9 to 12 millimeter lesion. It's different. But if you have a large, solid 15, 22, 25 millimeter lesion and the radiologist says, this is cancer, and everyone says they won't biopsy, I am okay.
Gracias. La última pregunta, estamos ya sobre el tiempo. El cáncer de pulmón localmente avanzado, candidato a QTRT, y en centros con gran concentración de pacientes, como pueden ser en nuestro país, en México, sabemos que la imagen guiada debe de ser diaria y como tal es un reto, es complicado. Si no fuera este el caso, ¿qué es lo que recomendaría como mínimo?
Is this the question about how often to get daily imaging?
Sí.
I mean, if you have to go quicker, every other day would be okay, maybe every third days, but I would get the MV and align to the carina. I think that's a very good surrogate. The MV portal to the carina is very good. And as recently as a few years ago, that's what I did. And I got one cone beam every week.
Excelente. Doctor Moghanaki, agradecemos mucho su excelente presentación. Igualmente a AstraZeneca para que esto pudiera haberse llevado a cabo. Y a todos los asistentes también les damos las gracias. Y nos vemos nuevamente aquí en 6 semanas. Gracias a todos. Buenas noches.